I need to start with a little bit of a disclaimer, okay? This is really not a talk about somebody who shows up and you have no idea what their history is and their blood pressure is elevated, okay? That's a very dangerous circumstance, especially at the levels we're going to be talking about here in terms of blood pressure elevation. To take them to the operating room and not know whether this is an acute episode that's related to a FEO or thyroid storm or et cetera is dangerous, and I would not, and I know of no one who would suggest in a non-emergent circumstance that you would proceed. The talk is really about the chronic hypertensive that shows up and has profoundly elevated blood pressure and what we should be thinking and what we should be doing and whether we should be canceling that sort of case or not. So here's our case. A 65-year-old gentleman for a right total hip repair is in the same-day surgical area preoperatively. It's about 7 in the morning. His only history is that he has high blood pressure. He takes a beta blocker for that, and he says he did not take his beta blocker that morning, that he normally takes it around 7 and did not take it. His heart rate is 78, but his blood pressure is 200 over 115, and he denies any complaints or discomfort. He has no headache, he has no blurred vision, he has nothing whatsoever. He's completely benign and normal from an exam standpoint. So how about some thought questions to frame the discussion that we're going to have? Do you think his elevated blood pressure could be secondary to him missing that morning dose? We'll come back to that. Is the systolic or the diastolic the more important? So was it the 200 over the 115 that concerns you more? Should you cancel the case? Should you take that patient and put him in some dark room and then keep retaking the blood pressure to see how many times you can take it and see if it's related to stress in the morning and et cetera? Should you put him in some space, put an IV in, and give him some midazolam or something that's an anxiolytic and see whether his blood pressure controls, and then decide you're going to do the case if his blood pressure comes down, but you're not going to do the case if it doesn't come down? Or should you go to the OR and have your anesthesia team manage the patient appropriately? Those are going to be some of the things we're going to touch base on. The whole history of perioperative blood pressure being a concern at all starts back, at least as far as that I could dig and find, with Ed Sprague producing a publication back in 1929 saying that perioperative hypertension was a risk factor for a bad outcome. This was a chart review work that they had done, and they saw blood pressure as a risk factor. Now here's the problem. In 1929, that article does not tell us anything about what the definition of hypertension is whatsoever. We have no idea, does he mean a 140 systolic, a 160 systolic, a 200 systolic, or a diastolic, or a mean arterial pressure number, or what? We don't know how they determined blood pressure at that point in time, and it's not even perfectly clear what type of patients. This is a 3.5-page manuscript, very common size manuscript for those days, not being derogatory in any way, but there's not a lot of information for us to understand. But we know that it sort of set the stage for people to say blood pressure is a problem. There were some people who started to talk about in the literature that maybe blood pressure is not the problem we think it is, but there were problems happening with patients. Hypertension, myocardial events, arrhythmias that were happening, and these cases were starting to get a lot of press. So people started to wonder as you get into the 50s and the 60s, is it really the blood pressure that's the problem? Or now that we're starting to treat hypertension, is it the meds that we're using? So things like ethacrynic acid, that was a diuretic that was used, or reserpine, that was an agent that was commonly used. And you see a proliferation of articles saying, maybe it's not the blood pressure, maybe it's a drug-drug interaction with anesthetic agents in these drugs, which leads to a whole series of basic science work looking for drug-drug interactions, and none could be found. So then you finally get into the late 1970s with Lee Goldman on this side of the Atlantic and Pris Roberts on the other side of the Atlantic, paralleling each other almost in lockstep in publications and commentary about the whole issue of perioperative blood pressure. They had almost the identical opinion with the same database and the same basic approaches and comments. I'm going to focus on what Lee Goldman has said. I could have easily focused on what Pris Roberts had said. It would be the same thing. So just to take a half a step back for a second, we need to know that when we talk about blood pressure, elevation in patients. About 25% of the time is it recognized and treated, 25% of the time recognized and poorly treated, and 50% of the time undiagnosed. So again, if this is the first time the patient's had an elevated blood pressure, I'm not advocating you proceed. That's a dangerous circumstance, not only because they can have an acute event intraoperatively related to blood pressure and or arrhythmias, if let's say it's a FEO, but you don't even know enough to know what drugs then to pick. If it's a FEO and you start beta blocking the patient, you then have unopposed alpha action, so their blood pressure gets even worse. Doesn't get any better in that case. So that's not what we're talking about here. What Lee Goldman and Pris Roberts did was start to ask simple questions. If blood pressure is a risk factor, is it blood pressure at admission? Remember, in those days, almost everybody having surgery was admitted to the hospital at least the day before having surgery. Very little sort of outpatient sort of stuff that we so commonly do today. So is it that blood pressure? Is it the one that happened at admission? Is it any history of severe hypertension? Again, not with great definitions, but some, and I'll come back to that in a second. Is it any history? It doesn't matter if you're well controlled or you're not controlled. Is it people who have had blood pressure elevations for protracted period of times versus short periods of time? Or does it none of that matter, and it's the blood pressure that you first get as you're rolling into the operating room that's the risk factor? Well, these were all good questions because Ed Sprague didn't tell us, and the other people who had published had not been very clear. And so if we're going to call it a risk factor, which one of these is the concern? Do you say don't do the case and have medicine, renal, cardiology, family practice, whoever it is, come and see the patient, and you want them to drop in an acute pill, change the blood pressure, and now it's okay to go to the operating room? The patient just had an acute change in their blood pressure on a medicine that they've never had before. So these sorts of questions become important for us to think about, and they pointed them out to us. So one of Lee Goldman's seminal papers is this particular paper by him and Deborah Caldera, published in 1979. And what they did was they looked at, just under 700 sort of procedures. All of these patients had general anesthesia. They believed that they were going to find high blood pressure was significantly connected to myocardial events. That was the premises, and sort of a positive hypothesis they had more than a negative hypothesis as their starting point. And they tell us a definition of hypertension. If the systolic was more than 160 or the diastolic was over 90, that was called high blood pressure. Here were the groups that they divided the patients into. You were a normotensive control. You were a normotensive patient on diuretics. That comes from that old literature that patients on diuretics seem to have more problems than other drug classes. So maybe there's something about diuretics. I want you to think, why would a diuretic be used in a patient that was not hypertensive, and what that may mean when we look at the data. So then there was the group that was hypertension by history, but is controlled. That could be for whatever reason. And then you had high blood pressure by history, high blood pressure showing up for their case, the group that's on meds, and the group that was, in theory, diet controlled in those days. So those are the groups. We start to get a sense of what they're looking for, and I bet you can start to think about why they divided those into those groups. What did they find? The first major finding, the only predictor of a perioperative hypertensive event were the operations and a history of hypertension. I'll come back to operation in 30 seconds or less. So what does that say? If you were hypertensive preoperatively, you were more likely to be hypertensive postoperatively. Not a lot of surgical procedures designed to change your blood pressure from a chronic standpoint, right? The operation were those with cross clamps on the aorta. So pretty logical. And then it says, especially if the history of diastolic was greater than 110. So does it say that there was more myocardial events if the diastolic was greater than 110? No. It says they had more hypertensive events if the diastolic was elevated. Okay? So that's the first misunderstanding, well quoted throughout the next several decades in all of the medicine anesthesia texts. If the diastolic's over 110, you should be canceling the case because that puts them at significant risk. And your answer today should be what? Significant risk of having hypertension postoperatively. Okay? Now, how about this diastolic over 110? I'll come back to in a second. So they also said that if you were inadequately treated, the group we would have some concern about, it would make some sense to have concern, that they were no more likely to experience a cardiac complication than the normotensive groups. That was the 1 and the 3, if you remember. Group 2 did, and they had a higher mortality. Now remember, that's normotensive by history, normotensive when they're showing up, but they're taking a diuretic. What sort of patients does that match? Well, maybe there's some with Meniere's disease or something, but probably a fair number of patients who had some form of congestive heart failure, probably a dilated form with significant peripheral edema and pulmonary edema by history on diuretics. Now, that's a different risk factor in a different group than we're talking about. But blood pressure was not the issue. So they did say this, especially if the diastolic was greater than 110. And if you have the material in front of you, you can already see what I'm going to show you. So how many patients out of that 617 or so did that really represent? And what complication? I've already told you. Yes, 5 patients back in the 1970s led to every text that followed saying you should not be providing anesthesia or surgery on the day if they show up greater than 110. Can you imagine that happening today in the world of evidence-based medicine? At 5 patients. This was an observation, a qualitative, not even really a quantitative observation. If we were standing here today, we would say, if we had any idea that people were going to change their practice as opposed to do further investigation, we would have never even put it in because it wasn't really a scientific thing. It was just something we thought we noticed in these 5 patients. They had more hypertension postoperatively. Maybe we should say that. And what did they have? Not myocardial events. Again, I'm not even sure the signal's big enough in 5 patients to identify whether there was a real issue or not. That work was continued. Here's a meta-analysis-like approach by Howe. You'll see down at the very bottom, the combined little diamond is to the side, favoring that high blood pressure may be a perioperative risk. But I think what's important is you see how close it is to the line of identity. You see that essentially every single study except for maybe one crosses the line of identity. And what did they actually show? They actually showed and said in their own conclusion that their data is not homogeneous, that the association is statistical, but they did not believe that there was any clinical relevance, and that they could recommend anesthesia and surgery should not be canceled on the grounds of just the elevated blood pressure. So I still remain some concern, still made me nervous. Maybe if they have high blood pressure, there's a whole series of articles, and those who do anesthesia have seen, these patients are very labile. It looks like a little bit of gas or a little bit of agent, and they get a little hypertensive more so, and then they have acute swings up and acute swings down. One person wrote an editorial once calling this alpine anesthesia. So maybe it's that up and down swing that's a problem, and if we could somehow have control of blood pressure before they came to the operating room, we would see less of that, and that downstream there'd be less of an impact. The problem is it's almost impossible to design a study that allows us to look at this, if not impossible. You'd have to take a bunch of hypertensives who are poorly controlled, give them medications starting 3 months before surgery, and 1/3 of them have active meds and 2/3 don't. And then suddenly, about 2 weeks, subacute management before surgery, another 1/3 of their placebo pills turn active, and then the last group is getting an active agent on the morning of surgery in order to figure out whether you really need 1 day or 2 weeks or a longer-term chronic management in order to control risk. And the risk hasn't even been seen to be clinically relevant yet in terms of the myocardial issues. So not clear this study will ever get done. Let me just spend a couple of minutes as I wrap up on some issues that are associated with this. So I'm not going to spend much time here. If they're on beta blockers, you should continue them. More and more people think you should continue calcium channel blockers. There's not a lot of data. It becomes more clinical practice. I think everybody still agrees that holding diuretics, you get electrolyte abnormalities. The patient goes into an induction of anesthesia, usually hypovolemic, is a good idea not to give on the day of surgery. At least preoperatively. And then you get into some controversial issues. Again, could be a whole talk unto itself on what to do with long-acting drugs, especially ACE inhibitors. It was a long period of time they were just always held. They were always held because of this. This is hours from the last ACE inhibitor for when they could still have profound hypotension. So you can see that goes all the way out 24 hours and beyond. And so this scared a lot of people, led to ICU admissions, so people began holding ACE inhibitors. What that's led to is more perioperative hypertension, and so more and more people were beginning to say, well, maybe we should be giving them and then trying to deal with this in a different way. We started with these thought questions. Let's revisit them. I'm not going to do an ARS, but, you know, could the elevated blood pressure be secondary to his missed AM dose? If his blood pressure goes to 200/110 every day that he's 5 minutes late in that morning dose, he's not controlled the rest of the time. That just doesn't happen, no matter how much that's what we always hear. Well, he missed his AM dose. It's not really the answer here. Is it the systolic, the diastolic, or what? Well, that's unclear, although we think that it's diastolic. Keep in mind, most of the time these blood pressures are going to be by cuff. Different types of cuffs have different approaches, but most cuffs actually only accurately measure mean arterial pressure. And then they might measure systolic or diastolic depending upon the company and then calculate the other. So you may be paying a lot of attention to a number that's a calculated number, not even a real measured number that you just got. Should you cancel? I think you get the sense now. The answer would be why. The person has no symptoms. They're not meeting the definition of hypertensive urgency or emergency. This is chronic hypertension, poorly controlled. You can manage it perioperatively, probably better than you could just taking a stab in the dark, increasing their dose of medicine, and waiting days to find out whether that had any impact on their blood pressure or not. Probably doesn't hurt to put them in a dark room. I don't know how it helps. I don't like this bullet at all. To give them benzodiazepine or something that's an anxiolytic as a gatekeeper means some you're going to take to the operating room, probably should have gone anyway, and others you're now going to say, now you can't go home or can't drive home because I'm now giving you an agent that prevents that. I don't know how that helps either them or us. And would you go to the OR? We would say yes for this sort of a case with those caveats. If they have postoperative hypertension because of the catecholamine surge, if they don't have a contraindication for beta blockers are still very good. There are many other choices to consider. Keep in mind that fluids may actually help control blood pressure in some patients, so a little more talk about that tomorrow when we talk about diastolic dysfunction. People will push at the end and say, but you talked a lot about myocardial events. How about stroke? There's not a lot of great data there. The little data that exists would mirror this particular study where you see they actually looked at it and they found that age, gender, diabetes, and systolic blood pressure were not predictive. They did not look at other things. The only thing that was predictive was pulse pressure, something we're not even talking about right now. So not really clear what to do with this information, but no clear data that taking this sort of person to the OR really increases their stroke rate at all. The conclusions are on this slide. Postoperative hypertension is a risk factor for preoperative hypertension is a risk factor for postoperative, sorry. There are a few studies that show that hypertension is any risk, and those that do exist did not control for heart rate control in a group of patients who have myocardial ischemic potential, and we understand that heart rate control issue is a double hit potentially for the heart. Sorry, I'm having trouble with the clicker today. Intraoperative blood pressure, if you're going to take them to the operating room, you should be keeping around 20% of what they were preoperatively. And if that's a problem, the surgeon says, I can't operate for what I'm going to do at a blood pressure that's around 20% of that baseline blood pressure. That's a different reason not to proceed to the OR. But if the surgeon is fine with proceeding, then you should be proceeding and trying to keep them close, right? Remember, the more you're chronically hypertensive, the more your autoregulatory curve shifts. So you want to try to stay closer to what their routine autoregulatory curve is, not force them to be normal, which would be hypertensive. You can titrate beta blockers in patients, especially some short-acting ones. I'd be very careful with things like labetalol and et cetera that can last 4, 6, 8 hours. If the case is fairly short, then you may very well have a person who is hypotensive on the other end produced by your drug management. If they meet that definition of uncertain, unclear what their history of high blood pressure is, or it's a hypertensive emergency, then I would not proceed.